Welcome to the Dana Parish Podcast, Third Opinion. Today I welcome Dr. Ziyad Al-Aly, a distinguished researcher and physician at the Washington School of Medicine, who you probably know from his remarkable research on COVID and long COVID. Named one of Time's most influential people in health, today we are discussing his groundbreaking new study on GLP-1 drugs, where he reveals newly discovered benefits and risks that should change the way we approach these powerful treatments. I'm excited to hear what you think. Drop a comment and please don't forget to subscribe. You just conducted one of the largest studies that we know of on GLP-1s. I have so many questions, and I know this is one of the hottest topics right now across medicine and mainstream press. I've never seen anything like it. It's really, really been fascinating to me. So if you don't mind, let's just dive right in. You studied 215,000 patients over almost 4 years. So that's a really long time. And you had a control group of 2 million people. What were your main findings?
Sure. So we started thinking about this topic actually several years ago, well before the COVID-19 pandemic, where we had to sort of put it on a hiatus when the COVID-19 pandemic broke out, and we sort of devoted our resources to studying COVID and long COVID. But we sort of figured out that this is, GLP-1s are kind of the new kid on the block, that these are new class of medications, and we wanted to know what they do in terms of risks and benefits. What are the beneficial effects of these GLP-1s,
Right.
and what are the risks of the GLP-1? And I know a lot of people sort of focus on their effect on diabetes, and that's well known. And now they become actually really extremely or spectacularly popular for their effectiveness and weight loss. So everybody knows them for that. But we wanted to sort of comprehensively analyze their effects on all outcomes, on all health outcomes, leaving no stone unturned. Basically, we wanted to discover, whether these drugs are doing something else, besides or in addition to their effect on diabetes and their effect on weight loss. And what we've seen is that the result from the study, again, as you mentioned, it's about more than 200,000 people who were on GLP-1, compared them to 2 million controls, individuals who would have qualified for GLP-1 but were not started on GLP-1 at the time, and then follow them for 4 years. What we've seen is that GLP-1 receptor agonists, or GLP-1, were associated with reduced risk of a significantly reduced risk of several health problems, including substance use disorders, psychotic disorders, seizures, and that was really a big revelation for us, neurocognitive disorders like Alzheimer's disease and dementia, coagulation problems, the blood clotting, so they also reduce the risk of blood clotting, reduce the risk of heart problems, and reduce risk of infectious illnesses and some respiratory conditions. But they were also associated with increased risks. So these drugs are not without risks. They were also associated with increased risks of several conditions. And I know a lot of people sort of talk about GI side effects of GLP-1s, and that's true. So there is clearly GI side effects: nausea, vomiting, acid reflux, sometimes constipation, sometimes diarrhea, stomach cramps, all these gastrointestinal problems. But beyond gastrointestinal problems, we also saw in some individuals actually results in low blood pressure, so low that it actually leads them to faint or leads them to have what we call syncope in some instances. Some arthritic disorders, or some sort of a joint pain and joint problems, kidney stones, kidney inflammation, to the point that it may actually result in some individuals in impaired kidney function, acute pancreatitis, and that's actually very serious because in very rare instances could also be fatal. So really, in this comprehensive analysis addressing 175 health outcomes and leaving no stone unturned, we feel, or we think, that we characterize sort of the broad effectiveness and risks of GLP-1. They do have a really wide profile in terms of benefits, but their benefits are not only confined to weight loss. They do much more than just weight loss, but they're also not without risks.
How do they work? What's the mechanism?
So there are multiple mechanisms related to GLP-1. One, the chief mechanism by which they may actually help with weight loss is delayed gastric emptying. Is that they actually make people, when they eat even a small meal, they make them feel full.
Is this causing gastroparesis?
Possibly yes, but it's sort of it really slows, gastric motility, and in some individual that can take some extreme form to the point of gastroparesis or stomach paralysis. And if that happens, that's really a major side effect that would necessitate discontinuation of the medication and treatment to make sure that gastroparesis resolves. So one of the mechanisms is delayed gastric emptying. So people feel full, and other mechanisms revolve around potential effect of GLP-1 on brain centers that are involved in sensation of hunger. And a lot of people would describe the idea that they take GLP-1 and all of a sudden they don't feel hungry anymore. They don't feel like they're like chasing food anymore, waking up at 2 a.m. in the morning, really hungry with this gnawing feeling that is sort of that they cannot, they have to satisfy that craving, for food or craving for carb. And that could also explain why they have this really spectacular effect on weight loss. They curb, craving and food intake, specifically, carbohydrates, and subsequently may lead to weight loss. And there are likely other effects. They have there's been actually GLP-1 is actually not new. It became sort of very popular now, but they've actually been known for about 20 years. And there have been a lot initially in preclinical data, sort of studying the effect of GLP-1 in mice and experimental animals, and then subsequently in humans. There have been actually a large body of research showing that they have a beneficial effect on the heart, stabilizing endothelial function, reducing oxidative stress. That's sort of the stuff that is really usually leads to heart attacks and heart problems and strokes, and reducing overall inflammation. So they certainly have a beneficial profile. But again, nothing is without a cost. So there is a beneficial profile, but there's certainly clearly a slew of adverse events beyond the just gastrointestinal adverse events that are now commonly known in the national conversation, or commonly talked about in the national conversation.
I was fascinated by the neuropsych stuff that you published about. As you mentioned briefly, you lose your craving for alcohol too, and tobacco and marijuana, it seems like, and other anxiety disorders, depression, probably insomnia even, because these are all inflammatory conditions. Were you surprised? I had never heard that before till I read your study, and I thought it was incredible.
It is eye-opening. It is eye-opening that a drug that initially was developed for diabetes, now actually has a spectacular success in weight loss, and now we're beginning to unearth, other effects, including, those neuropsychiatric effectiveness, specifically substance use disorders, alcohol use disorder, opiate use disorder, cannabis use disorder, and nicotine use disorder, et cetera, et cetera. So really clearly, these drugs likely have a neurotropic effect, and likely their effect on the brain. So it tells us two things, Dana. It tells us that these drugs likely have a neurotropic effect, an effect on the brain, specifically on centers of the brain that mediate craving carbohydrates, treating obesity, craving nicotine, craving alcohol, or that need to sort of, satiate or need to quench that thirst for alcohol, et cetera, et cetera. That's number one. Number two, it also tells us something more profoundly important about obesity itself. That obesity, we think of it as, people sort of trying over consuming food, and that's sort of like mostly a behavioral problem. And I really think it sort of tells us that obesity is a chronic disease that's likely mediated by a brain problem. It's almost like a food addiction disorder or a food use disorder, and then that using drugs that target these centers in the brain, demonstrate a spectacular effect, really wonderful effect that's never seen in our fight against obesity. We've been, lots of people have been working on addressing obesity or figuring out what works for obesity for a long time, and almost everything failed. Diet, exercise, all these programs, Weight Watchers, failure after failure after failure after failure of people, doing all of this effort, investing all these billions of dollars in these programs that have spectacularly failed. And now there's something that all of a sudden goes to the brain and say, we're going to, sort of think about obesity differently, think about it as a disease of the brain, a disease that is really essentially at the core of it is a form of addiction to food. It's not a healthy relationship to food. It's an addiction to food. and then curbing that with GLP-1 or suppressing that with GLP-1 really ameliorates outcome and really results in this sort of a profound effect on weight loss. So again, for those people who are thinking like obesity is my fault, it's not your fault. It's a disease. It is a disease. And it can be treated, and that's sort of a GLP-1 is a prime the success of GLP-1 is a prime example of this way of thinking.
As a nephrologist, you deal with diabetes, right? I mean, that's one of your areas of expertise. So before the advent of GLP-1s, what were you doing to try to get people to turn back time on type 2 diabetes, which it seems like we can have some control over? Is that correct?
Correct. So even before GLP-1, there were a lot of medications that would address or reduce the risk of heart problems and kidney problems as a result of diabetes. Specifically SGLT2 inhibitors. So there were other things. And again, GLP-1 itself has been around for a while. People have been using GLP-1 for diabetes actually for a long period of time. And then, people discovered that in addition to controlling diabetes, GLP-1 also has this profound effect on weight loss. But sort of going back to the core question, there have been over the past 10 years or the past decade, it really also a revolution in our understanding of how kidney disease, how diabetes leads to kidney disease, and different therapeutics to ameliorate outcomes in people who have diabetes and reduce their risk of developing kidney disease. One of them is GLP-1 receptor agonists, but also there are other classes of drugs, including SGLT2 inhibitors, also really work very, very well. But traditionally, before this decade, we've also used what we sort of a renin-angiotensin-aldosterone inhibitors. And then, those include ACE inhibitors or RAS blockade, or renin-angiotensin-aldosterone system blockade, include ACE inhibitors or angiotensin receptor blockers. Those also reduce the risk of adverse kidney outcomes in people with diabetes. So really our armamentarium, or our sort of toolbox to combat the risk of having kidney problems after diabetes has actually expanded significantly over the past decade.
How much of obesity is driven by not just literally eating too much, but genetics or hormonal imbalances?
So I think this is a really complex question. If you sort of if it was genetics, if it was purely genetics, we would always have had really sort of a significant amount of or significant rates of obesity in the U.S. But it's very, very clear that in the U.S. and in Europe and actually in the rest of the world, there is sort of a almost like an epidemic of obesity over the past several decades, and that epidemic is actually worsening. And you would think that sort of countries, actually, for example, like China, that now they're actually starting to have obesity and starting to see it in young people and kids and in adolescents. So it's a disease of the changing food environment that we have, and really the overabundance of calorie-dense food, and I would argue also poor quality food. We have a lot of food, but you go to the supermarket aisle and you see all these chips and all these very, very carb-rich products, and that's really I think sort of is the primary fuel for the obesity epidemic in the United States. But that's not to say that it's this sort of a poor food environment that we live in nowadays. The food now is really mostly ultra-processed food. About 70% of the food in the Western world is ultra-processed food, 70%.
Let's just lay that out for people. It's not just like processed, like pasta, right? You're talking about Doritos and stuff like that. Like
all of it. Everything when you like flip back the bag and then you read a list of ingredients is like exceed 2 or 3 things. That's really processed or ultra-processed. And especially if you start reading things that you don't even cannot pronounce. Like monoxide hydrogenase. Like, and it's like, once we sort of get to that level of thing, these are sort of a really ultra-processed food with a lot of preservative and a lot of sort of chemical substance stabilize them, and to actually make them appetizing and make them taste very good and make you addicted to them, so you go back and buy more and make more money for General Mills and more money for other companies. So that food environment sort of permeated every household, like, rich, poor, everywhere in the United States, and then sort of really fueled the obesity epidemic. And it's not really only here. Obesity, although less of a problem, but it certainly is a problem in Europe. And although it's less of a problem, but certainly a problem and rising very sharply in East Asia, including China. You would think that Asian people are really small and thin, but that's no longer the case. If you look at the adolescents and young individuals in China, obesity rate is really spiking dramatically. That is, again, as a byproduct of the changing food environment, and then the abundance now of ultra processed food that arguably is and I would argue is toxic to human health. But it's not to say that really that because food is available, people sort of have somehow it's their fault that they're becoming obese. It's not a behavioral issue. It's certainly not sort of driven by people lack of will. When you're present in an environment that's 70% of your food environment is ultra processed food, you consume that food, and as a result, you gain weight. So again, while the GLP-1 likely will make a significant dent in the obesity epidemic in the United States, I think the focusing on prevention is going to be also very, very important, trying to figure out what are sort of root causes of this really massive obesity epidemic, and targeting ultra-processed food and targeting other sort of drivers or the root causes of this problem is going to be very, very, very important to really ameliorate the health of Americans. And in other countries also look at the food supply chain as sort of one of the major drivers for the obesity epidemic.
We want the food supply cleaned up. Like, we deserve that. And so there's all this press and all these terrible stories about all these people. Okay, like politics aside, if you just look at the issues, I am very much in favor of cleaning up the food supply.
Yes.
We should be looking at vaccines, honestly. We should be having these conversations openly. I do not think that any of this should be hidden and off the table, so to speak.
Trust.
Yes,
I mean, I think
exactly.
what the major problem in this pandemic is that there's a massive erosion in public trust. And I think one of the ways to regain it is actually to work collegially and to demonstrate to the public that we may agree or disagree on things. That's actually healthy, but we need to work together to really materialize progress for the American people, because that's really, really missing. And it's really it's baffling, and I'm going to reiterate it because it's so important for everybody to understand it, is that we're the wealthiest nation on earth and the most scientifically advanced nation on earth. We actually invent most of the science that help other nations do better than us, and yet we trail behind all these nations and health outcomes. That should not be acceptable to anyone. That should not be acceptable to anyone. Absolutely not.
And people need to understand, like, these foods and stuff, these are coming from hugely wealthy, extremely powerful corporations.
Oh, yes.
And it's no accident. By the way, I was thinking when you were talking earlier about like the chips, I don't eat a lot of in my like prior to 2020 life, I probably wouldn't have even ever bought a bag of chips in the last 20 years or something. But COVID hit, can't go anywhere. What do? I go like, oh, I'll get some tortilla chips and some guacamole. Well, don't you know, like, all I could think about was those damn chips, like day after day. And I was buying bag after bag. Before I knew it, I was like, I think I gained like 10 pounds. Like, I need to stop. And it was the chips.
It's real. It's real.
Exactly. And I'm not addictive as a person at all. Like, I've never had an addiction. I'm sort of like the most moderate. And then here I am, obsessed with these damn chips, and I'm like, this is a real problem. Like, I have a problem. I gotta stop.
And this is not a coincidence. They make them so. They engineer them. They engineer these products with all these substances and all these molecular design. So you crave them, and then you go back for more, and you go back for seconds, and you go back for more, and then what's sort of the consequence? What's sort of the byproduct or the result of all of this? It's weight gain.
It was weight gain, and I felt bad, and I felt guilty. It's sort of like the what the hell diet. What the hell? I'm home, stuck home, things suck. I'm just going to eat whatever I want. It's such a trap, and it's such a slippery slope. I'll have one bag. I'll just have one more this week. Oh, they're on sale. I'll get two. Anyway, so here we are, and I did stop buying them, but I'm telling you, it was a long time of thinking about this stuff.
Yeah, and it shows in the waistline of Americans. So like, that's really very, very clear.
Absolutely. Back to the GLPs, I was wondering, one of the things that you mentioned was about infectious diseases. And there's so much overlap in the symptoms that you mentioned with what you are seeing and what you've studied and published on in long COVID and in COVID. Can GLPs have a role in long COVID? And the patients that were on GLPs, did they have any lesser risk of a bad COVID outcome or even a highly symptomatic
This is
case?
brilliant. This is brilliant. And this is a very, 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 very important question. Actually, so I don't have we're studying this. We're actually doing studies right now to try to evaluate whether people who are on GLP-1 and then subsequently get SARS-CoV-2 infection, if they have better outcomes in the acute phase and also in the post-acute phase or the long-term phase, in the long COVID phase. I don't know. We don't know the results yet, but we are doing this. So you're definitely, your finger is on it. So this is really, we think it's a very, very important question because, if the hypothesis is true that GLP-1s do all these wonderful things, specifically stabilize the endothelium and reduce oxidative stress and reduce inflammation. Well, guess what SARS-CoV-2 does? Sort of provokes this, inflammatory mayhem and disrupts endothelial function. And if there is something to antagonize that mayhem and then try to keep it in check, like GLP-1, would that really also lead to better outcomes? And I think that's really the question we're asking to try to better understand whether GLP-1s actually really work, specifically in the setting of people who had SARS-CoV-2 infection, both in the acute phase and in long-term phase.
Interesting. I'm dying to see the outcome of that study.
If this is really truly ameliorates outcomes of long COVID, or let's say cardiovascular disease after long COVID, or other conditions, it could also tell us that likely that the mechanism is mediated by things that GLP-1 touches or GLP-1 affects. And that sort of would be an additional mechanistic insight into why long COVID happens.
So when you mentioned earlier about how it can help with infectious diseases, what were you referring to?
So we've seen a reduced risk of pneumonia, for example, and that's really with a revelation. It's like, why would GLP-1 receptor agonists or GLP-1s reduce the risk of pneumonia? And I think it's like we were saying, it because likely it sort of has an effect on the immune system overall, and perhaps also endothelial function and epithelial tract function, sort of the health of the cells and the respiratory tract. This is maybe one of the reasons why it also reduces the risk of adverse events after having, or reduces the risk of infection and post-infection outcomes. So that's really what we've seen. We didn't study specifically in the setting of COVID, but I think that's really that's what we're doing now, and the results there will help us, sort of flesh this out a bit more.
In terms of dementias and neurocognitive disorders, and it even seems like neurodegenerative stuff, what's the result there? And at what point, if this drug is instituted, do you think it could actually be helpful in those areas?
So we definitely seen a reduced risk of Alzheimer's disease and dementia. However, the risk reduction was really modest. It's not like really it reduces the risk of Alzheimer's disease by 50%.
Yeah.
It was literally about 10%. It's a very, very small risk reduction, but was there consistently so. Reduced risk of Alzheimer's disease and dementia. Now we ask, like, why is this really happening? Likely, and there have been studies have been done on this, that GLP-1s reduce neuroinflammation, reduce deposition of something called sort of the tau proteins in animal models of Alzheimer's disease, not humans, animal models of Alzheimer's disease. So it's likely also, again, has an effect on the brain, on neuronal function and reduce neuroinflammation and stuff in the brain. That's why maybe it reduces the risk of Alzheimer's disease. Second possible pathway is that, and really I think we should also talk about this a bit, is that it's possible that obesity itself is sort of the mother of all ills. Is that obesity itself is really, especially in individuals with really massive obesity, like say people who have a very high BMI, they have really high degree of inflammation, and it's possible, like living in those bodies for so long, in that inflammatory milieu and all those, all that inflammation is also toxic to the brain. That addressing obesity, reducing the risk of, or reducing BMI itself, and make people feel better, less inflammation, and all of a sudden their neurons are not sort of like swimming in this sea of inflammation that characterizes obesity, and they also perform better, they also do better. So these two mechanisms are not mutually exclusive. So, and again, I think one of the key explanations as to why GLP-1 have this sort of a very wide pleiotropic effect, effect across many, many outcomes. It's almost like works everywhere. Like somebody could come up with a conclusion like, okay, well, like, oh, you're saying it works here, it works here, it works here, like it works everywhere. Like why? Like how so? It's possible that one of the possible explanations is that, well, obesity also, negatively affects all these different organ systems. And then all of a sudden abrogating or attacking obesity and reducing obesity and the inflammation that ensues from obesity, from having all those fat cells storing all this massive energy in fat and provoking that chronic inflammatory state, reducing that or abrogating that inflammation is beneficial to health and then ameliorates all these different problems, including Alzheimer's disease and dementia. So I think these possibilities are there. What is very clear, though, epidemiologically, at least in the data, empirically in the data, what is very, very clear is that there is a reduction in the risk of Alzheimer's disease and dementia, but the risk reduction is really small. So that you asked me a question like, what would that really mean? Sort of in terms of would GLP-1s be seen, at least in the current doses that we use them, as therapeutic options for Alzheimer's disease? Unlikely so, because the effect's so small. So you can't really rely on them only to treat Alzheimer's disease, but they may serve as adjuvant, as sort of almost like a supportive therapeutic approaches that may work in tandem or may amplify the effect of other drugs, right? So they may, you and I talked about combination of drugs for, say, COVID and long COVID and all of that before. So sometimes one drug alone, like metformin alone, may or may not be sufficient. And sometimes the wise strategy is to say, okay, well, this drug alone is not going to do a whole lot, but a cocktail or a combination of drugs, and we've talked about it before, Dana, and in the context of COVID, may actually do better, may actually lead to better outcomes. And maybe the same thing. Maybe the same thing here. Like on their own, don't think that they are, again, the effect that we've seen an effect and it's there, but it's not huge. It's not like it's going to solve the Alzheimer's disease crisis, right? It's not going to. So it's a small effect, but it in combination with others may actually be a game changer.
Very interesting. Yeah, it is one of my favorite things to talk to you about. I'm always calling you, what do you think about adding this drug for an early COVID infection? Because I think that's where we're going to land. Like, I think we really want to solve the long COVID, prevent long COVID. I think we're going to be looking at a combination of therapies, since we don't have anything to meaningfully block the infection other than like no exposure. And that's not very realistic for 99% of people at this point.
No longer realistic. No.
I see a lot of comments and a lot of things get directed to me about, can you believe so-and-so isn't wearing a mask anymore? Like, pictures of scientists and stuff. And I think, we can't be saying this at this point. This is 5 years. This is not going away. You cannot have this expectation of people to live in a bubble. It's not minimizing the risk. It's just saying this is the reality of life. And so that's why, I'm such a proponent, and I know you are too, of early treatment and of figuring out ways that we can help while we have to live with this. You know what I'm saying? Like, it's living in the reality of the times.
Yes. Testing and treatment for sure. Like testing to recognize what it is, because there's a lot of viruses around. It could be COVID, it could be RSV, it could be flu, could be and treatment as necessary. That's correct.
Absolutely. I watched a podcast the other day about GLPs. One thing that I thought was really, really interesting was microdosing them. There was a doctor on Mark Hyman's podcast. I think her name is Tina Moore. She was great, really interesting and smart. And she said that she's been doing this for herself. She has psoriatic arthritis, and when she gets really bad flares, she's tried everything. She eats like, perfect diet. She looks like a picture of health. She said nothing has helped except this microdosing of GLP-1s. And she said she's been using it on a lot of patients, mainly not for weight loss, mainly for other things, chronic diseases, inflammatory things. It has had the side effect or benefit for some of having them still lose some weight. Maybe it's not extraordinary, but she also said that she's in a network of other doctors, and they communicate, and who are using this, microdosing this, and they're all seeing the same incredibly wonderful benefits and really no downside from what she said so far. So I'm wondering what you think about the possibility of
This is a very, very, very interesting concept. And I have to say, there's the caveat, major caveat, this has not been studied in the randomized controlled trials, so we don't really know.
We're just speculating.
But it is very popular in the patient community, especially the patients that they source their medications, from compounding pharmacies. There's sort of the different, microdosing is not going to be available to people who really are actually getting it from, let's say, CVS or Walgreens and the prepackaged pens, right? Because that's the dose is well defined. Like the pen is 2.5, like Zepbound, for example, whichever sort of prescription they have, Monjaro or Zepbound. So it's really already, the dose is already packaged in the pen that resembles, for those who really are not familiar with this field, like it resembles an EpiPen, right? Like so it's already there, so the microdosing is not available to them. Microdosing is available and actually very popular among patients that source their medications from compounding pharmacies, because they could actually literally pick the dose that they want. And anecdotally and clinically, there is a lot of sort of positive, as you shared, feedback from it, and actually people are using it for all sorts of indications, not necessarily only, weight loss. Some people actually, think that it actually clears their brain, helps them feel better, more energized, and suppress that inflammation, reduce arthritis or like joint pain, the example that you cited, and multiple other things. And certainly there is it is a thing out there. I want to make sure, again, like to mention on here, that this has not been studied in randomized controlled trials. So we don't really fully know sort of the advantages and disadvantages of an approach like microdosing, but it's certainly very popular in the patient community. And again, I'm seeing, the effects that we see in our data of more than 200,000 people and all these beneficial effects, and that the effect actually, for a lot of these outcomes is likely, will only need like a teeny dose to sort of suppress inflammation or improve oxidative stress. So it makes sense to me that those anecdotal reports are likely what's actually happening. And again, it requires study.
At this point, pharma should be paying attention to these conversations and possibly thinking about making different dosages for different reasons, maybe for different people. Because if you're telling me, I can go to a compounding pharmacy, and you're not saying this, but I did hear this on the podcast, for $20 and get a little microdose of something that could help me that much. And then versus a very high dose at CVS for thousands of dollars that has a lot of side effects potentially. I'm leaning towards the microdose myself.
Correct. What is also very clear, Dana, I'm glad you mentioned, because you put your finger on it. What's very, very, very clear is that the side effects are dose dependent, meaning that you get a whole lot more side effects, let's say with a Zepbound of 5 or 10 or more than you get with 2.5. And then that sort of a lower dose or microdosing actually can or may, I should say may, gets you the benefit without having to experience the risks or adverse events.
Yeah. Interestingly, again, anecdotal stuff, but she said she has not found any of the common, any side effects at all. But the really common ones that I tend to hear about most are extreme nausea, lack of appetite, just feeling like, just yucky, just sort of bad.
Yeah, GI side effects are a big deal, certainly. It's sort of like one of the major organs where these GLP-1s really work is the stomach, by delaying gastric emptying. And it's certainly, in some people, they throw up, and some people, they have this sort of a bad reflux, where it's like, oh my God, it's almost like this bad heartburn, nausea, vomiting. Some people may even have constipation and stomach cramps. It varies, but gastrointestinal side effects are certainly a big thing. Same form of it, we've talked about it. It could be gastroparesis or paralysis of the stomach, and that's certainly not a trivial thing. But it could also happen, albeit rare. But it's certainly one of the side effects of GLP-1.
And it does seem like it could keep people staying on these drugs and receiving the benefits if they could really reduce those side effects. I'm sure lots of people stop taking them pretty quickly. When, like for me, if I was nauseous on a drug, unless I was going to die without it, I would not take it.
This is a very good point. You're putting your finger also on a very, very, very important topic. So these drugs work, but I think unfortunately, not only because of the side effects, because also the exorbitant cost that is associated with these drug discontinuation rates in the first year of utilization is very high. in some studies it's 70%, in some studies even 90%. So people start on them and hoping that they want to lose weight and they want to do this and they experience side effects and they stop, or they figure out like, well, it's exorbitant. Like even with insurance, for some individuals it could be $300 a month, and that's or $400 a month or $500 a month. Without insurance, it could be $1,000 a month. $1,000 a month. So people sort of realize very quickly that they cannot sustain this cost. They may be able to get 1 dose or 1 month or 2 months or 3 months, but they cannot keep up with this really exorbitant cost that also lead to discontinuation. So that really also needs to be solved, because while these drugs are available and then these drugs are effective in the context of the American landscape and American medicine, they're exorbitantly costly. And that also, I worry that this also creates a significant sort of a disconnect between availability of therapeutics that actually may be able to help and access to these therapeutics to actually make sure that their help is really moving the health of the American people forward.
I'm kind of concerned about some of the side effects that I've been reading about lately. One is blindness, sudden blindness. Is that a concern?
So we did not see that in our data. It doesn't mean it doesn't exist. It doesn't mean it doesn't exist.
Did you see the recent headlines about it? Did you see that? Yeah.
So experiencing sort of blurry vision and some changes in vision is not unusual after GLP-1. So that's not unusual, but that's not blindness. That's sort of people sort of experience sort of blurry vision or changes in vision, and especially if they have a sort of a refractive, or if they wear glasses and all that, they actually some people may even need to change their prescription after GLP-1 because it sort of changes, especially for people who have diabetes and their blood is sort of used to high level of glucose, and all of a sudden that goes down. That sort of osmotic gradient goes down. So the lenses in their eyes sort of adjust shape. They have to adjust sort of the new pressure in their or the new sort of osmotic pressure that is sort of this one of the mechanisms that is sort of that is a result of a lower glucose level than it was before. So there are these changes that could happen, but that's not blindness. Again, we did not see that, but it doesn't mean it doesn't exist. Like we did our best to try to catalog and map all side effects. Doesn't mean it doesn't exist if we haven't seen it in our data. I think more needs to be done about this to try to help us more deeply understand all the side effect profile of these medications, because they're not going anywhere. If there's one thing is very clear, and you see the projections to 2030, utilization is going to continue to climb and climb and climb. More and more Americans are going to want to be on GLP-1s because they work, and we definitely need to understand their benefits, but also far more importantly, I would argue far more importantly, we also need to understand their side effect profile fully, so we're not really exposing our people to unnecessary risk, or if something happens, also we understand how to mitigate it, how to reduce that risk.
Absolutely. I have heard one or two physicians that I admire raise a concern about potential pancreatic cancer. Do you think that's possible, or do you think it's an unlikely outlier?
So it's possibly What's very, very clear is that in rare instances, GLP-1 will result in acute pancreatitis. And so they actually provoke an inflammation in the pancreas, because, one of the things they also act on in the endocrine system, including the pancreas. So it's possibly that they sort of provoke an inflammatory cascade in the pancreas, resulting in acute pancreatitis. And that we see very clearly. And there's been multiple reports sort of suggesting that that's also a thing, not only in our data, but outside our data. The risk of pancreatic cancer, I would think that cancer generally takes a long time to manifest. Generally speaking, cancers require significant duration of exposure to the drug, meaning that you'd have to be on GLP-1 for years, and then subsequently, that sort of may result in pancreatic cancer. So we don't see that. And again, we're only limited by what we see now. Sort of we see in our data about 4 years worth of follow-up, close to 4 years worth of follow-up. We don't see what happens to these people who took GLP-1 for 10 years, because obviously we're still studying this, so we don't have 10 years of follow-up. We'll see increased risk of pancreatitis down the road with a longer follow-up. Maybe, possibly, yes. I think it's very, very clear that it certainly in some individuals it leads to increased risk of acute pancreatitis. And that's not a small thing. Acute pancreatitis can literally put people in the hospital. It's not a benign thing. It's very rare. It's 2 to 3 people per 10,000 individuals. So that's very, very rare. But it's certainly, is there, and in some cases can land people in the hospital, and even worse, can sort of result in fatality or death after acute pancreatitis. So it's not a trivial or inconsequential adverse event, but it's very, very low. It's very rare.
Another concern that I've seen is that it can waste muscle, including the heart muscle. Is that correct?
So including the heart muscle, I don't know that. So that's really not borne out by studies. One of the things actually, one of the indications, Dana, for a GLP-1 is actually heart failure. And actually, in randomized controlled trials, it ameliorates outcomes of heart failure. So the people actually have, for the people who really have a weak heart muscle to the point that they actually have heart failure, their muscle is not really contracting, is not really working vigorously or sufficiently well, and they have a condition we call congestive heart failure or heart failure. For those individuals in randomized controlled trials, the people who took GLP-1 actually did better than the people who did not take GLP-1 with respect to heart failure outcomes, including death and hospitalization for heart failure, et cetera, et cetera.
That's now, so interesting.
Skeletal muscles, so heart has a different kind of muscle than skeletal muscle, than muscles that are sort of around the bones. Those the muscles that we use to sort of lift things that shape our bodies, right? Like external muscle or skeletal muscles. So skeletal muscles, they're definitely correct. So there is, with weight loss, with delayed gastric emptying and calorie deficit or a negative caloric intake or a calorie deficit. So what really happens is that the body does not only lose fat, it also loses skeletal muscle, loses muscle mass. So that's definitely a thing. And that's actually, it's not a small thing, because, you definitely want to lose the fat, but you don't want to lose skeletal muscles, because skeletal muscles is really what allows you to move around and function and be healthy and exercise and go to the grocery store and lift those bags and put them in your trunk and do all those things that we do to live our life. So skeletal muscles are actually what we rely on to be. So you don't want to lose that. So, and the trick in people who are using GLP-1, the trick there is to try to maximize protein intake. So GLP-1 reduces your appetite, and all of a sudden you're gonna find yourself you don't have the appetite, you're not eating as much, but you also need to pay attention to what you eat. So even the little that you eat, it needs to be enriched with protein or protein-rich diet or high protein diet to try to reduce the risk of skeletal muscle loss and maximize the fat loss, but not skeletal muscle loss. And that's very, very important. And then you mentioned the microdosing. Some of the proponents of the microdosing regimen will actually say that tiny, teeny doses will help you actually get rid of very slowly of the fat, albeit slow. So it's not going to be a slower journey, a slower but more steady journey that preserves, the skeletal muscle mass. So, but help you get rid of the fat, albeit slowly, but more steady journey. So some of the proponents of those regimens will say that, and I also, again, I find it very, very plausible. Very, very plausible that this may be the case, and that the astronomically very high doses will just shut down your appetite, so you stop eating, you're in this calorie deficit, and all of a sudden you lose 100 pounds. Guess what? Like 50 of that is your muscle, and then you don't want to lose muscle mass. You want to lose the fat, but not the muscle, because that's really what's going to protect you and help you, maintain a healthy and good lifestyle. So skeletal muscle mass is absolutely a thing, and figuring out how to reduce that risk or reduce risk of losing skeletal muscle while maximizing the benefit of getting rid of the fat is really the trick in management. And it requires, again, proper dosing of GLP-1 and also proper diet that is high in protein.
Is this getting the fat out of the liver?
Yes. So I love that. I love your question. So one of the trials that have been done on GLP-1 is ability to ameliorate outcomes in people with fatty liver disease, or in some cases called non-alcoholic steatohepatitis, NASH.
Why do people get that? Outside of alcohol, why do people get that? Is it
metabolic
food?
syndrome, insulin resistance. And so that obesity is like when we accumulate, fat cells, it's not only around our waist, it's everywhere. It's everywhere,
Yeah.
including in the liver and in between liver cells and in between the liver cells and the bile duct and, in the liver. So people have this, so what we call like a fatty liver disease, or in the old days, they used to call it non-alcoholic steatohepatitis or NASH, and has a sort of other names as well.
Are there symptoms, or is it just you must have your liver sonogrammed or something?
In the very early phases, it's totally asymptomatic, and generally, people start finding things on elevated liver function tests, and like say an ALT or one of the liver function tests was elevated in early in the course of the disease, and then so depending on the stage of the disease. Now, at advanced stages where it's really fulminant or elevation of all liver function tests, and also abnormalities on imaging. Abnormalities on imaging could also be seen in the early phase, but
Sure.
Generally it's asymptomatic. So people can, I think because of the obesity epidemic in the United States, actually a lot of people who are obese also likely to have some form of fatty liver disease or some form of fatty liver disease, albeit most would have like the mild form. And if you dig deeper and do ultrasounds on these individuals, or MRI or other form or imaging modalities, you'll discover that they also have fat. Again, what we see on the outside is like, people have these like large waists and sort of a high BMI, and that's not only happening on the outside and what's visible to us, it's also happening in internal organs, especially the liver. So the root cause for all of this, Dana, is that eating calorie dense food or for a long period of time induces a state of insulin resistance, and that sort of then begets you also the problems. Like weight accumulates. Subsequently, people may develop early forms of diabetes or pre-diabetes, and then frank diabetes, and then also the metabolic complications, including also fatty liver disease, also hyperlipidemia or forms of dyslipidemia, where the HDL, the good cholesterol, is low, LDL, the high cholesterol, is high, or triglycerides is also high, or both of them are high. And all of these things are actually happen together. They're not sort of people sort of try to or tend to think of them as sort of isolated things, but they're collectively they belong to sort of this broader sort of a metabolic syndrome or broader constellation sort of disorder, again driven by overconsumption or consuming high calorie food or ultra processed food for a long period of time.
What do you think about the downstream effects of GLP-1s in terms of getting us off other drugs like statins or beta blockers, things like that? Is that in the pipeline?
It is a thing. So it's if the and we see this actually with the hypotension, with the and some people ask me like, why are these people having hypotension? Because they're actually on blood pressure medicine, and they take these GLP-1 and they lose 50, 60, 100 pounds, and all of a sudden their blood pressure is better, but they're still on the blood pressure medicine. What does that do to them? Dana, that actually induces a state where they and now have a low blood pressure. So that can potentially happen. So people, especially if obesity is the major driver of that high cholesterol, if obesity is the major driver of all these other problems, then addressing obesity, addressing the root cause of this problem may actually obviate or eliminate the need for downstream medications down the road, like say blood pressure medicine or high cholesterol medicine or other things. That's definitely true.
Can you ever get off of these drugs?
So I think this is what we really are sort of trying to wrap our head around at this point. I think I think people need to recognize that obesity is a chronic disease. It's not a sort of a disease that comes and people who have obesity, they likely have sort of a again this sort of a state of insulin resistance and some form of chronic disease that led them to have obesity in the first place. And then managing obesity, like managing other conditions, is likely to require long-term approach. Now, whether the long-term approach will be all of it GLP-1 or maybe initially GLP-1 and then subsequently a maintenance dose of GLP-1 and other things plus lifestyle modification medication plus sort of a, maybe other agents, remains to be seen. But I think what is very, very, very clear is that, and we've touched upon the people who really discontinued GLP-1 because of either cost or side effects. What's very, very clear is that the rebound, weight gain is astronomical. So people lose 100 pounds and all of a sudden they have this yo-yo effect where they, within literally, 2-3 months, they regain that 100 pounds. Yeah. It's like, how can someone gain 100 literally in a few weeks? And that's actually happening. So that sort of a treatment with GLP-1 for a 6 months or a year or two is unlikely to, it is going to result in weight loss and it's going to get them to the goal. But I think, maintaining, that weight loss is going to require a regimen that also likely will entail use of GLP-1 or some sort of a, some sort or similar drugs to sort of maintain that weight loss. We see sort of repercussions of stopping, GLP-1. But that, if I may, also creates sort of the one of the conundrums that I think, like, I think so. We're almost like trading addiction to food or dependence on food to now becoming dependent on GLP-1. Like, like sort of like that sort of creates some sort of dependence. Like, will I need to be, or that person needs to be on GLP-1 forever for the rest of their life? And then does that really mean they're now like dependent on GLP-1? And I think that sort of, I think, needs to be in the national conversation. That needs to also be fleshed out more scientifically to try to understand what do these drugs really do long term, like 5-10 years down the road, are we trading one dependency with another dependency, and sort of what are sort of the ramifications of that? And I think that needs to be fleshed out more.
It's a very polarizing drug. I will say that I have never quite seen the landscape like this over. I mean, sure, in the age of COVID, I guess things have been different over Paxlovid, over the COVID vaccines and things, and ivermectin, all those kind of things. That's true. But in terms of take those out of the equation, I've never seen any kind of like public debate like this about a drug class. And there are people who are very upset about these drugs and feel we're creating people who have the same habits and we're not trying to improve food quality and we're just numbing them and it's creating drug dependence and we're enriching pharma. And then there's even Elon Musk tweeted, though, that these are the most important drugs. I'm paraphrasing, so it's not a direct quote, but these are like the most important drugs of our time. And he said that he takes, I'm not sure how you say it, Wegovy?
Mounjaro. No, Mounjaro. I think he takes one of them. Yeah, I forgot what it is. Yeah. But he definitely takes GLP-1. He said that on X. He said it publicly. So there's, and he also said something like, and if you argue with me, I'm going to turn out to be right at the end of the day. So don't bother, sort of thing. So, I mean, where do you fall on the spectrum of this debate? I think both are right. So I think there is very clearly the case to be made for prevention, for prevention. Our food sucks, ultra processed food and all of that is really bad quality. And this is what got us here in the first place, right? Yes. So that's very, very, it is very, very clear for the proponent of, prevention is king, or prevention is really is absolutely, there is a role for prevention. There is a role of like soul searching here in the, that we literally are one of the, if not the richest nation on earth, but yet our outcomes are not so good, and we need to improve that. And it's very clearly it starts with our food. But it also, like, I definitely see the allure, the role for GLP-1 and the profound importance of GLP-1 and actually addressing the problem in those who already got it. So for the people who already got it, who already have obesity, who already have a BMI of 30 or 35 or 40, who already have obesity. I've tried a million things in the past, Weight Watchers, this diet, this Atkins diet, this other diet, this high protein diet, this high fat, all these other things they've tried, like, failure after failure after failure, and now they land on something that works. It's very clearly it works, right? So very, very clearly, undeniably it works. So I think there is a role, I think there's a role for a more nuanced conversation. I think both are important. Prevention is important, and preventing, the young kids from having obesity. So we don't need GLP-1 in the future, absolutely. 20, 30 years from now, right? The people who are now, preventing people who don't have obesity from getting obesity. But to say to somebody who is like who've tried everything and failed, who's like now has a BMI of 40, that we need to focus on prevention or ultra processed food, and like that doesn't mean anything to them. People who already have the disease, I think we need to conceptualize obesity as a disease. It's not a failure of willpower. It's a disease. It's a chronic disease state. It is a chronic disease state, and we need to really think about it as a chronic disease state. You wouldn't say to somebody with cancer or hypertension, oh yeah, well, eat better. Maybe when cancer will go away, eat better, because it's not going to go away. Now, if you don't have cancer, does eating better and avoiding toxic food maybe reduce your risk of cancer in the future? Yes. So prevention is key. Prevention is really important.
Right.
But for people who already have the disease, for people who are already suffering from high BMI and metabolic syndrome and insulin resistance, I think making GLP-1s widely available and accessible to people at affordable cost is really going to be very, very, very important. And I think now, obviously, Musk can have it, he can afford it, but I worry that a lot of the Americans who actually really need it more than him are not able to access it, or are able to access it for a month or 2 or 3. And we talked about it, 70 to 90% of them discontinue the drug, primarily because of financial concerns or inability to keep up with the payment required. Even when they're insured, even their copay could be $300 or $400. And for some people, Dana, $300, $400, it's a rent or half a month of rent or something, for some people. So that's really not a trivial cost. Maybe to Elon Musk, doesn't care, like $300 or whatever, or maybe even if he pays full cost, like $1,000 a month. So that's really in making sure that the medicine is available and also is accessible to the people who are needed is going to be important. And this is also what sort of to broadly reflect on the national conversation. This is what I actually don't like about the national conversation a lot of times. It's like one or the other. It's either prevention or treatment. But there is a role for prevention and treatment.
You're for us or against us.
Yes, but that's not how life works, because what? Prevention is important and treatment is important. They're not mutually exclusive.
Right.
They are not mutually exclusive, and we need to sort of have a more nuanced conversation about these things, and both could be true and important, right? So improving our food supply and focusing on prevention is very, very, very important, and we should do that, as well as providing access to these medicines for those people who already have obesity, because prevention and somebody who already had cancer or already had they already had it. They already have it. They already have it.
It's like
don't talk to me about prevention. I already have the problem, right? Preventing it and maybe 20 years ago, but I already have it now. We need to treat it, right?
Absolutely. It's like the COVID conversation that we've had a million times. It's like, well, you should have worn a mask. Okay, well, I wanted to go to my family's Christmas dinner, sorry. And I wanted to eat, and it was 30 degrees out. I mean, at some point we just have to give people grace and have these nuanced understandings and conversations of these issues, because there's a real world aspect to it. It doesn't mean that you don't take all sides seriously, but it also, just as a scientist, right? Isn't it just a hallmark of science and a tenet of science to be asking questions, digging further? What is the truth as we know it right now?
Well, absolutely. Scientists are truth seekers, right? We definitely, being curious and asking the right questions and seeking answers and making sure that these answers are actually also communicated. So science is useful to people. Sort of what I don't like about some of the, as a scientist, is that they do this wonderful research, but then they keep it to themselves, or they don't talk about it enough. And I think science communication is also key. So definitely science is about truth seeking and making sure that truth is also available to people, so it's useful to improve people's lives.
Before you were really in the spotlight for COVID, you were doing a lot of great work in air pollution and other areas of science. Were you surprised by the kind of craziness around being more public about scientific findings? And did you get a lot of pushback when you were publishing on these enormous studies on COVID outcomes, COVID in the brain, COVID in the heart? And
yeah, the pandemic itself has been politicized, and there's sort of really a lot of, everybody has an opinion, which is good, and some are not very nice about it. Some are not very nice about how they communicate their opinions. And I think that we deliberately focus on picking questions or identifying questions that are really important to the public. So out of all, we could do studies on things, on a million other things, but we choose to, focus our scientific pursuit on questions that really matter to the public. And when we have results, we actually also focus on quite a bit on science communication. So we do a lot of effort deliberately to communicate the science, and that generally, sort of and with the purpose of actually having a discussion. And I think, that stimulates a natural conversation. Now, because COVID, it has been politicized, and there's sort of really a lot of people who are entrenched in their camps, and they're unwilling to have sort of a graceful or a really cordial conversation or collegial conversation. Sometimes it sort of devolves to attacks and all of that. But I think it comes with the territory. I've definitely received my share of attacks and things during the pandemic.
When we wrote our book, I was getting mostly wonderful support. But then there was like a small faction of science shills and people working on the behalf of other people. I never told this before to hardly to anybody, but certainly not publicly, but I actually had a doctor show up at my house and threaten me to be quiet. I mean, yeah. But he literally showed up at my apartment under the pretense of, actually, I don't want to say what it was. I don't want to give any hints as to who it was because I don't want any more aggravation. But yeah, he came by under a premise that seemed very legitimate. He's very well known. And basically what he wanted to do was tell me to back off, because the book was about, the underlying causes of the infectious causes, including COVID, of chronic disease. Seems pretty non-controversial on the surface, and it shouldn't be. And it's a really science-backed book, but I think it was a real problem to those who want to peg things as autoimmune to create drugs that treat symptoms and don't address the root cause of chronic infections causing this wide breadth of diseases, from neurodegeneration to rheumatoid arthritis, MS, all those kinds of things. So yeah, there's a big pull to deny chronic infections, as you know. And I was the recipient of some really scary stuff.
There's a lot of that. And sometimes I get like these really nasty emails about things. And my favorite is somebody called me an educated idiot, so like thank you for saying educated, but that I don't understand epidemiology, and I don't understand data, and I don't understand how the world of statistics works. And I'm educated, but an educated idiot. So I mean, I got a lot of these things, but I generally tune them out as sort of and I understand people are passionate and they're coming from their point of view, and I sort of in the thick of it, we're super busy trying to sort of move things forward, and there was very little time for me to even think about these things. I just didn't sort of have time to even just delete and move on, delete the email and move on, or not engage.
Very smart of you.
Yeah, this is really great. Your questions are amazing. Your questions are amazing, Dana. You're it's really honestly so smooth and wonderful to talk to you about these things.
I've been, a long time admirer and appreciator of your work. It really emanates that you care so much about people. I know you care so much about the world. So,
thank you.
So
Dana.
Can we come back and do a part 2?
Yeah, we'd be more than happy. COVID and long COVID, and maybe even the politics in the United States. More than happy to.
Let's do that.
I mean, I thoroughly enjoyed this. I really thoroughly enjoyed this. Yes.
Thank you.
So smooth and so wonderful to just have a chat. Yeah.
I'm excited to continue our conversations, and just thank you for everything.
Thank you for hosting me, Dana. Hopefully 2025 will be a wonderful year for all of us.
Thanks for joining us today. Please subscribe or follow along for more really interesting conversations. And I'd love to hear from you. So please drop a comment or send me a note. Let me know what you think.